Thank you so much. It's a pleasure to be here, and I congratulate our team, Sreenethra, especially Ashad and Harshali, for conceiving this wonderful idea of having a concept of admitting mistakes and going beyond the boundaries, going beyond the protocols. In benign tumors of the eye and head neck, so obviously the goal is to conserve vision, but in malignant tumors, salvage of life is the primary goal, salvage of the eye is the secondary goal, and providing optimal residual vision is the tertiary goal. So in certain situations, you end up, especially in malignant tumors, excentrating the orbit, enucleating the eye, or losing vision to save life. That may not always be the situation. Protocols actually cage you. And once you get out of the protocol, there's a wide world out there for you to explore. And similarly, in the realm of management of orbital and ocular tumors, this principle applies. And the hard fact is that the diseases don't read books at all. You have to discover a disease as you see more and more patients, you get experienced. And protocols generally address only the middle of the spectrum. There are outliers which the protocols don't address. Or if you practice protocol-based management in the outlying clinical situations, sometimes you harm the patient, not do good. The question is, can we conserve yet improve life salvage, eye salvage, and vision salvage? Can you avoid loss of vision, enucleation, or exentration in many clinical situations? Let's talk about eyelid tumors with orbital extension. Earlier, 5 years ago, we were uniformly exentrating them. Of course, it is mutilating, but does it benefit the patient? Now we have multimodal treatment, and with orbital exentration, we had such high mortality. Despite extremely good surgical cure in the area that is involved, the patient would die of systemic metastasis because we are not taking care of systemic microscopic metastasis. Now, can we conserve this patient? This patient has a large sebaceous gland carcinoma, other eye has suboptimal vision. Of course we can. When you give neoadjuvant chemotherapy, the lesion starts shrinking first cycle, second cycle. After 3 cycles, lesion is confined to the medial 2/3 of the lower lid, eminently amenable to excision and reconstruction. This patient again has orbital involvement, and after chemotherapy, now you can easily excise this. So neoadjuvant chemotherapy has brought about hope in these patients to avoid exentration and also save the eye. Similar situation by multifocal sebaceous gland carcinoma involving the upper and the lower lid and also the conjunctiva to a certain extent. Following neoadjuvant chemotherapy, it's become amenable. This young patient had sebaceous gland carcinoma, unusually of the lacrimal sac. Somebody had done a DCR and has let the cat out of the bag. Tumor has extended through the ostium. He has 6/6 and 6 vision, and he wants to conserve. We don't want to exentrate him. So we started with neoadjuvant chemotherapy, chemo-reduced it, did dacrocystectomy, extended dacrocystectomy, of course, and stereotactic radiation. And he lives on with his eye and vision saved. Orbital extension of basal cell carcinoma, we would have exentrated this patient. Now with local excision, frozen section, controlled excision with skin graft and adjuvant EBRT, she lives on. For difficult cases, we have targeted therapy as well, especially with vismodegib and sonidegib becoming available in India. We have hope for patients with multicentric basal cell carcinoma and also basal cell carcinoma with orbital extension. This was an example of a basal cell carcinoma where earlier you would have exentrated or have done mutilating surgery. Now we can conserve this by just this oral medication. Of course, this medication is expensive, not readily available, but it is definitely possible. Now this is from the literature where erlotinib was used. This patient had wet ARMD in the right eye and his vision was poor. In the only good left eye, he had this orbital tumor and the eye was displaced and the pupil was not exposed and he was in the hospice, not amenable to any surgical intervention. So when they started on erlotinib, which is epidermal growth factor receptor inhibitor, his tumor reduced in size and he was allowed to see because his pupil got exposed. And he lived on with whatever little vision he had and carried on his normal activities until he died of other unrelated clinical situations. So basically, you can use these for temporizing a particular problem where surgery is not possible. In ocular surface tumors, we have, if you go by the literature, we have huge recurrence, 25 to 40% recurrence. That's why we bring in oncological principles. Topical therapy works beautifully well. surgery works beautifully well, but we have to have edge as well as base clearance at surgery, and we have to bring in histopathology guided adjuvant therapy. Unless you don't practice these two, your chance of recurrence will be very high, 25 to 30%. The edge is very easy to determine. You can do a slit lamp evaluation. You can see that this is the edge, that thickened part of the conjunctiva will also have dysplasia. That's also considered to be the edge. And beyond that, you go 4 millimeter and you're done with the edge. But base is opaque. You can't see the base on slit lamp evaluation. You can only conjuncturally assess the base by trying to move the tumor on the epibulbar surface with a wet cotton tip applicator, etc. Base can only be imaged by OCT or UBM. You can only visualize the base, and that particular tumor shows only conjunctival involvement. That bubbly layer is tenon, so your plane of dissection will be episcleral. That's very clear. Now, what if the base is involving the corneal stroma or the sclera? This particular patient, clinically, there is no way to tell that the corneal stroma is involved. When you do UBM, you find that the corneal stroma is splayed with internal reflectivity, that is normal cornea. So obviously, this particular patient will need either a penetrating keratoplasty or plaque brachytherapy. Good news is that pathology correlates with OCT, and that we use all the time. So in a given patient with ocular surface squamous neoplasia or conjunctival melanoma, you find on imaging that the sclera or corneal stroma are already involved, or if a patient has intraocular extension, or you have excised it and the pathologist tells you that the base is positive, what are you going to do? These were considered beyond conservation, and we were doing orbital exentration or extended enucleation in these patients 5-7 years ago. Now we no longer do that. We use either plaque brachytherapy, stereotactic radiation, chemotherapy, or targeted therapy. Now, there are two situations when plaque is done. One is primary plaque brachytherapy. When you have a problem with the tectonic integrity of the eye, when the corneal stroma already appears melted and you cannot safely excise this eye without losing the tectonic integrity of the eye, you would do a safe biopsy from one part of the tumor that appears safe, and for the rest of it, you apply plaque directly on top of the tumor. That is primary plaque brachytherapy. There are good calculation protocols now, and these patients work very well. This is the same patient after primary plaque brachytherapy with 3D conformal dosimetry. We didn't do excision here at all. Now, this patient has multiple prior excisions for a conjunctival melanoma, and now it has recurred in his sclera. That is the extent of melanoma, that he has 3 prior excisions elsewhere without margin control. And on UBM, you find that he has intraocular extension, a limited intraocular extension, about 1.1 millimeter thick. You can see the ciliary processes. When we can treat melanoma of the ciliary body, which are 6 millimeter thick, why can't we treat melanoma in the ciliary body, which is just 1.1 millimeter thick? We don't have to enucleate this patient or exentrate this patient. So we did excision of the tumor and did brachytherapy, which is rotational plaque brachytherapy. And 5 years later, you can see that his eye is salvaged. So you can use these methods for conservation of the eye. Again, this is a patient with nodular melanoma with a scleral component. This was excised, and this part was treated with brachytherapy, and you can see the results after about 5 years. So secondary plaque brachytherapy is done when you have excised the tumor and the pathologist confirms that the base is involved. And prior to surgery, you have only doubt that the sclera may be involved, and on excision you find that the base is involved. So what do you do for the base? You treat it again with plaque brachytherapy after the ocular surface is resurfaced. After about 3 to 6 weeks, you apply plaque in the area of the tumor that is involving the sclera, and these patients do well with about 90% eye salvage. This was published. Now about stereotactic radiation. This young individual has ocular surface squamous neoplasia, multiple prior excisions, medial rectus was involved, so they have resected part of the medial rectus as well. Now he has unfortunate intraocular extension, choroid as well as ciliary body. Clear case for extended enucleation, every oncologist would agree. The patient has choroidal as well as exudative retinal detachment. MRI confirms there is intraocular extension. Patient is not keen on losing the eye at all. He is only 22-year-old and has life ahead of him. So my radiation oncologist designed a stereotactic field for him. We gave chemoradiation. While we gave radiation, we also gave carboplatin, which is radiosensitizer. You can see that his choroidal and retinal detachment have settled, and his intraocular extension, ciliary body extension, both have regressed following this treatment, and he's able to have his eyes saved. On MRI, again, you can find that the intraocular extension has resolved. About targeted therapy, there are two forms of targeted therapy. One is locally delivered targeted therapy. The second is systemic. For systemic therapy, we use simiplimab, which is not easily available in India. You have to order by patient and very expensive. Locally delivered are interferon, for example. This patient has diffuse squamous cell carcinoma, not just of the bulbar conjunctiva, but involving the upper as well as the lower palpebral conjunctiva as well. In such situations, we were exentrating earlier. Now with a combination of injection interferon and topical interferon, took about 6 months for him to get treated. But at least 50% of patients respond this well. Other half obviously need to be exentrated, but this one did well. Now for lymphoma, conjunctival lymphoma with orbital extension. This patient had diabetic retinopathy already. In patients with diabetic retinopathy, when we give radiation, you obviously worsen diabetic retinopathy. So we did not want to give radiation to this patient, yet take care of his orbital extension, which is just like a sliver hugging the eye, going back beyond the equator between the superior rectus LPS complex and the sclera. The anterior component was easy to excise, and for the posterior component, we gave perilesional rituximab. This is a targeted therapy, obviously locally delivered targeted therapy, and that took care of the orbital component. Now, about the intraocular tumors, diffuse choroidal hemangioma is often subjected to external beam radiation, sometimes with consequences of radiation retinopathy, etc. Now, in diffuse choroidal hemangioma, you don't have to treat the entire diffuse component. You simply have to treat the nodular macular component, and these patients do well, and that can be done with plaque brachytherapy, thus conserving vision. Diffuse choroidal hemangioma, nodular macular component treated with brachytherapy, tumor became nearly flat and the patient had good vision. For melanomas which are overhanging the optic disc, juxtapapillary, with the notch plaque configuration, we can easily treat them. You don't have to do enucleation. For patients who have a tall melanoma like this with a narrow base, you can do partial lamellar sclero-uvectomy, and you can preserve the retina. Of course, you will need the help of a vitreoretinal surgeon when you want to do it. You can see nice retinal vessels and the component of the choroidal tumor completely gone, with the sclera being visible there. For retinoblastoma, intravitreal topotecan 30 microgram was practiced very well. We were very happy with the results. Then we started getting situations where it was refractory. The tumor was refractory to the standard dose of intravitreal topotecan. This is one example where the patient has this retinal tumor and this bunch of vitreous seeds. Retinal tumor regressed after intravenous chemotherapy. Then we started intravitreal topotecan. 6 injections, seeds are better but not completely gone. This was 30 microgram era. Then we had to add melphalan, which is a bad drug because it causes retinal pigment epithelial atrophy. Seeds went away, but we are not very happy with the consequences that it left in the retina of retinal pigment epithelial atrophy, including some damage in the macular area. So we started exploring higher doses of topotecan, 60, 90, now even beyond 100. So when we increased the dose of topotecan beyond what the protocol prescribed, we started getting good response. So all these seeds beautifully went away after 3 to 6 injections of intravitreal high dose topotecan. Now, having learned from that, we have extended the indications. Now we use intravitreal intracameral topotecan for anterior chamber seeds. You can see this is post-treatment. We use intravitreal topotecan for epiretinal and subretinal seeds which are earlier lasered. When you laser this area, obviously there will be scarring that can be avoided by doing intravitreal topotecan in these patients. For endophytic budding, cottony appearing discohesive retinal tumor, which is impossible to laser, you have to only treat them with chemotherapy. That can be taken care of by intravitreal chemotherapy. And for desperate situations like this, where the other eye is already lost, where there is ciliary body involvement, for that component, ciliary body component, we do plaque brachytherapy, and for the anterior chamber seeds, we give intracameral chemotherapy, and for the vitreous seeds, of course, intravitreal chemotherapy. With all these combined, this patient continue to have good vision. In primary orbital retinoblastoma, earlier there was 50 to 70% mortality with orbital exenteration. We no longer do that. Here we do what is called multimodal treatment. We begin with neoadjuvant chemotherapy for the orbital component. When that regresses and the eye goes into phthisis, you do an enucleation with a long optic nerve stump, then deliver stereotactic radiation for the microscopic residual, and then follow it up with 6 more cycles of adjuvant chemotherapy. That is 12 cycles of chemotherapy. Sandwiched between that would be surgery and radiation. With all these put together, what we achieve is cosmesis and much better life salvage. You have nearly 90% life salvage with in orbital retinoblastoma with multimodal treatment. And the advantage is that even intracranial extension, which were earlier given up as untreatable, can also be taken care of. This patient has cavernous sinus involvement, completely gone with neoadjuvant chemotherapy. What is left at the superior orbital fissure can easily be treated by stereotactic radiation, and these children live on. But for the patient, what is the benefit? It's the cosmesis. These children don't have to undergo orbital exenteration. With a well-designed radiation, you can avoid contracted socket, and they can wear a good custom ocular prosthesis. Brief about orbital tumors. This patient is an airline pilot, but he has gone to a temple obviously before he visited me. Why does he have to do that? Because he has this orbital tumor lying at the orbital apex, impinging on the superior orbital fissure, causing visual field defect, because of which he has been grounded. And he is very scared of undergoing surgery because he already read about it, talked to many ophthalmologists. The consequences of operating in the superior orbital fissure, orbital apex area, even if you are a good surgeon, and also cavernous hemangioma is a surgery that you enjoy doing because it simply comes out. But when you dissect here, there are consequences of loss of vision and also nerve palsy. You cannot dissect at the orbital apex or superior orbital fissure without consequences. He has visual field defects. How do we tackle it? Again, we took the help of a radiation oncologist. He delivered low-dose stereotactic radiation. Following that, you can see much smaller tumor reduced in size, and his visual field defect actually returned to normal, and he went back to work. So this is possible when we extend indications for radiation to involve even benign tumors or avoid surgery where surgery is not feasible. About this child, he had eosinophilic granuloma. Clinico-radiologically, there was not much doubt about it, but he has the roof missing, the dura involved. Treatment of choice for eosinophilic granuloma, curettage. Would you curate in the area, in this particular area, or try to debulk this tumor with consequences of CSF leak? Probably you would not. So what we do here is, we do a safe biopsy from the center of the lesion. Child waits under anesthesia for about 15 minutes. The pathologist, if he is confident, will give the diagnosis then and there that it is eosinophilic granuloma. Most of the times we get that confirmation. Then under visualization, we inject just a 40 rupee drug, triamcinolone, right into the lesion. Once we have the confirmation, that is exactly what you can do. And over a period of 3 months, the bone is partially remodeled. Over 6 months, there is complete remodeling of the bone without any morbidity of surgery. So this is minimal interventional technique where we confirm the diagnosis histopathologically. For example, it could be anything else as well. Clinico-radiologically, just our suspicion doesn't mean anything. So we have to confirm the diagnosis. Now about orbital dermoid. This child has a large orbital dermoid. Again, a surgeon's pleasure to excise orbital dermoid. But she does not want a scar. There are situations where patients don't want a scar, and we cannot do it by lid crease approach because the tumor is lateral to it and it is also adherent to the periosteum. So situations like this or dumbbell dermoid, we give what is called sclerotherapy. This uses volume expanded sodium tetradecyl sulfate. You mark the boundary of the lesion, aspirate the contents. You already know that the contents are going to be fluid by MRI. You don't do it for thick contents. And then inject volume expanded sodium tetradecyl sulfate. That's how you expand the volume. You run a 1 cc of the drug through 2 syringes which are connected and make it into a foam. This is STDS foam sclerotherapy, and inject right into the lesion. And the same child did very well. You can see that her tumor has regressed after 3 months and she did not need any surgical intervention. This is again extended indications of sclerotherapy that is used for saphenous veins, etc. for orbital conditions. As far as surgery is concerned in orbital rhabdomyosarcoma, complete excision of the tumor can sometimes be bad for the patient. specifically in this patient where the tumor is all around his inferior rectus muscle. So if you were to excise, we have to excise the inferior rectus, and the strabismologist in the room would agree that strabismus is difficult to correct even if you transpose the muscle. So what do we do here? Purposely, we leave a wedge of the tumor around the course of the inferior rectus. That is the wedge of the tumor that has been left in the patient, and the tumor has been excised. So what do we do for the rest? Obviously, chemotherapy and radiation, which are anyway required in patient with rhabdomyosarcoma, and the patient continues to have good ocular motility and no diplopia. For adenoid cystic carcinoma, this was Fairu's work when she was a fellow. We recently got it published as well. Adenoid cystic carcinoma had 50%, 75% mortality, so it was a treacherous tumor to treat. We no longer excise it, no longer just do excision or no longer just do radiation. We do the entire thing. We excise it, do stereotactic radiation, and also give adjuvant chemotherapy. And even this bone which is destroyed because of the tumor gets remodeled over a period of time. So that's multimodal treatment for adenoid cystic carcinoma with 95% eye salvage, 80% vision salvage, exentration necessary in only one patient. This was an unusual situation where the patient had recurred following all forms of treatment. That is the tumor that he had. After chemotherapy, tumor reduced, but there was residual tumor. Patient had already received radiation. So in this situation, we do what is called afterloaded brachytherapy. We implant these silicone tubes at the bed of the tumor, and following which the patient is sent to a radiation oncology facility. Iridium-192 seeds are used through these portals to deliver radiation right up to the tumor base. So in conclusion, I would say that people with ropes around their necks don't always have to hang. We can avoid orbital exentration, enucleation, and vision morbid management procedures in many patients with malignant and some patients with benign tumors as well. Thank you so much.